Hi there, this is Dr. Gollogly. Today we're going to look at a really interesting example of the MRI scan and the CT scan of a 26-year-old athletic male patient with a bilateral spondylolysis defect and go over why that diagnosis can sometimes be difficult to make on the lumbar MRI scan. So this image that you see moving over here is the MRI scan of the lumbar spine. This is the CT scan of the lumbar spine. These are both sagittal images, and I've oriented them so they're about the same plane in the spine. This is the L5 vertebral body here, 5, 4, 3, 2. In between each of those is the intervertebral disc, so this would be the L4-5 intervertebral disc here. And behind that is the spinal canal filled with the nerve roots that go down into the legs. Now we can perceive that there is a slight disc bulge here at the L5-S1 level, and this patient has axial back pain, but that's not this patient's primary problem. When we scroll over to the side of the spine, we can appreciate here, if we zoom in on this area here, the foramen where the nerve root comes out and goes down to the leg. So I'm going to draw around the foramen here. So that's the foramen there. And then inside the foramen, we can see the nerve root quite clearly there. But we don't get a great sense of what's happening back here in the posterior elements. If we come over here to the side of the CT scan, we get a completely different picture. So there is a stress fracture of the pars interarticularis located right here. I'm going to draw around the normal contours of the L5 vertebral body, and here we're going through the top of the pedicle of L5. This is the superior articular process of L5. This is the pars interarticularis right here. This is the inferior articular process of L5, and then back to the rest of the vertebral body. So this little gap right here represents a stress fracture in the part of the vertebral body that's in between the superior articular process here and the inferior articular process here. And if I grab my arrows here, the way that I understand this condition to occur is that repetitive hyperextension of the spine in the adolescent spine before it's fully developed creates a stress fracture by creating a nutcracker-like effect or repetitive squeezing of the pars interarticularis by the L4 vertebral body on the S1 vertebral body. And then over time, this stress fracture develops into a cleft, and in this case, this has been present for a significant period of time because we see good cortication of the ends of the bone, indicating that the outer surface of the bone has healed over and there's no longer any connection between these two. Now that's something that's very, very difficult to see here on the MRI scan, but it's quite easy to see on the CT scan. So in this case, the treatment of a pars defect can actually be quite difficult. There are some techniques in which it's possible to try a direct repair, but by the time there's good cortication of the bone here, oftentimes a direct repair is very difficult to accomplish without iatrogenic damage to the facet above or below. It's very common that these patients will also have leg pain because as the nerve root sneaks out through this little bony channel down here, oftentimes there's some inflammatory tissue that develops along the bottom of the pars interarticularis defect that irritates the nerve root. So the treatment for this condition is usually rest and avoidance of the activities that are causing pain, maintenance of a good core strengthening program, and trying to stay as active and as fit as possible. Bracing does help in a situation where someone's in an acute amount of discomfort, and some trials with bone stimulators have shown some success. Anyway, the point of this quick little exercise is to demonstrate how difficult it is to see that pars defect on an MRI scan and how immediately apparent it is on the CT scan.